Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. I would like to introduce today's speaker, Dr. Aslam Ajaz. He is the Chief of Surgical Oncology and the Associate Medical Director for the Oncology Service Line at the University of Illinois, Chicago. He is a high-volume pancreatic surgeon and a clinical and health services researcher whose efforts are focused on delivering patient-centered care for patients with pancreatic cancer. Thank you for joining us today.
Hi, my name is Aslam Ajaz. I'm the Chief of Surgical Oncology at the University of Illinois, Chicago, and I'll be speaking today about surgical care and outcomes for patients with pancreatic cancer. Just some brief objectives. So we'll go over the indications for surgery, the diagnostic evaluation of patients with pancreatic cancer, preoperative optimization for patients potentially undergoing surgery, the different surgical approaches, post-operative care, and a brief talk about perioperative outcomes after surgery. And so, as you all know, the overall survival of pancreatic cancer is still very dismal. The 5-year relative survival rate still is only about 12 to 13%. There's 66,000 cases in 2024, but these account for 51,750 deaths. So it will be the third leading cause of cancer-related deaths in the U.S. And the stage of diagnosis is the most influential factor on long-term outcomes among patients with pancreatic cancer. And so as you can see on the bottom left here, the majority of patients, 51%, are diagnosed with metastatic cancer at presentation, and only 15% are diagnosed with localized disease and 28% with regional disease, which has spread to regional lymph nodes. And on the bottom right here, as I mentioned, stage significantly influences long-term outcomes. So patients with localized disease have about a 43% 5-year relative survival, regional disease 16%, and metastatic disease 3%. And so when we assess patients for surgical candidacy, we really rely on 3 main components. The first is anatomic resectability, the second would be biologic resectability, and the third would be physiologic resectability. And so anatomic resectability, we're assessing the location of the tumor versus the very important blood vessels that surround the pancreas. And this is often categorized as potentially resectable, borderline resectable, and locally advanced or unresectable, which I'll go over in detail in just a minute. Biologic resectability assesses the biologic aggressiveness of the cancer through various biomarkers such as CA19-9, Some centers are using ctDNA or circulating tumor cells, as well as response to neoadjuvant therapy. And physiologic resectability relies on evaluating a patient's frailty and their performance status. Just some pancreas anatomy as it relates to anatomic resectability. And so the pancreas sits behind the stomach, is surrounded by the duodenum, and the pancreatic head and neck overlie the SMV, which turns into the portal vein, which is the blue structure on the left there, and the SMA, which is just adjacent to it. The celiac axis originates above the neck of the pancreas, and has three main branches, which is the common hepatic artery, the splenic artery, and the left gastric artery. And these things will be much more important as we get to determining anatomic resectability. There are various systems to assess anatomic resectability. This is the NCCN guidelines on resectability status, and they're broken up into the three categories that I mentioned: resectable tumors, borderline resectable tumors, and locally advanced tumors. And they're also divided by arterial and venous involvement. And so resectable pancreas tumors are tumors that have no arterial contact whatsoever, no contact with the celiac axis or the SMA. Venous structures can be involved, such as the SMV or portal vein, but this is less than 180 degrees without any vein contour irregularity. Borderline resectable tumors can have contact with the arterial structures, such as the SMA, but less than 180 degrees, and can also have solid contact tumor with the common hepatic artery, but no extension to the celiac axis. On the venous side, borderline resectable tumors, again, can have SMV or portal vein involvement greater than 180 degrees with contour irregularity, but the involvement of the vein must be amenable to safe resection and reconstruction, which we'll go over in just a minute. For locally advanced tumors, for tumors in the head or Unson process, this is contact with the SMA or celiac axis greater than 180 degrees in terms of the arterial involvement, or for pancreas, body, and tail, same thing, 180 degrees with the SMA and or celiac axis and aortic involvement. With venous involvement, it has involvement, solid tumor contact with the SMV or portal vein that's not amenable to any resection or reconstruction. So when we assess anatomic evaluation, it's imperative to get a pancreas protocol CT or MRI, which is multiphasic CT with thin cuts. And these are just some representative images here. And so on the left-hand side is a resectable tumor. The tumor is in the middle of the screen. It's the hypodense lesion there that's adjacent to the bile duct, which has a stent. The SMA is just adjacent to it, but there's no apparent contact between the mass and the SMA. And the SMV does have some contact, but this is less than 180 degrees. For borderline resectable tumors here in the middle, this has greater than 180 degree involvement of the SMV there, but there appears not to be any involvement of the SMA, or very minimal involvement, possibly posteriorly there. And locally advanced tumors, the one on the right-hand side, here you can see that the SMA is clear, but the celiac axis is involved, as well as the common hepatic artery. And so this would be classified as a locally advanced tumor. Now, physiologic resectability, when we're assessing patients and their fitness for surgery, we're really assessing their frailty or the absence of frailty. And frailty is the physical ability, stamina, and endurance of a patient that's really trying to measure their physiologic reserve and or resiliency that they would have after surgery. This is particularly important as we have an aging population. About 20% of people will be over the age of 65 by 2030, and pancreatic cancer tends to affect the older population more commonly than the younger population. However, older age does not equal frailty, and so common saying that age is just a number can be true. It really is dependent on the patient's physical status and their physiologic reserve. And so frailty is really trying to determine their physical and cognitive deficits, and not necessarily what age they are. This is particularly important in patients with cancer, as they have many factors that may worsen frailty, such as malnutrition, cachexia, and physical inactivity. And furthermore, for patients potentially undergoing surgery for pancreatic cancer, they may have the added insult of preoperative chemotherapy or radiation therapy, which may further impact their performance status and/or frailty. And so to assess frailty, there are both objective measures and subjective measures, and these are just some of the measures that have been reported and studied. And so physical measurements of performance include things like a grip test, which has been well established, a timed up and go test, stair test, a 6-minute walk test, or simply assessing their weight and BMI to assess for particularly underweight patients. Whether or not they have cognitive impairment, there are various objective measures of that. There can be some biologic markers for things like sarcopenia, which is loss of muscle mass, which is evident on CT scans, or things like albumin, which measures their protein reserves. And then there's subjective measures such as patient-reported fatigue, or what's often commonly used is the eyeball test by surgeons. Now, this has been proven to be highly inaccurate, and so I would advise against this, but it can serve as a starting point for surgeons. Now, for patients who are frail or borderline frail, or even patients who aren't frail, preoperative optimization is key for patients undergoing surgery. And so we've really evolved into a multimodal optimization of patients before surgery, which includes things like exercise, nutrition, psychological evaluation and treatment, as well as smoking cessation and alcohol cessation if there is any ongoing. And this multimodal treatment can really not only prepare patients for surgery, but can also potentially convert patients who may be too frail and not candidates for surgery based on their physiological status to becoming patients for surgery, and really try to optimize not only their candidacy, but their outcomes after surgery. Our group actually studied this, looking at different comorbidities in a Medicare population of over 1 million patients. And we found that even just assessing their comorbidities can determine their frailty. And so we developed a scoring system that was highly accurate to determine a patient's perioperative morbidity, their readmission and mortality after surgery, which ultimately also resulted in higher costs, mostly due to the complications that they faced after surgery. As I mentioned earlier, an increasing number of patients are receiving neoadjuvant chemotherapy, both resectable, borderline resectable, and locally advanced patients. And this is just a brief overview of kind of the rationale behind it in the surgical population. Neoadjuvant chemotherapy is thought to increase R0 resection rates by downstaging the disease, reducing the bulk of tumor and potentially involvement of the vascular structures that I mentioned previously. About 30 to 40% of patients do not receive chemotherapy in the adjuvant setting, particularly after a Whipple operation, because of failure to heal in time. And so giving it in the neoadjuvant setting ensures that all patients receive at least some chemotherapy. And biologically, neoadjuvant chemotherapy can be given to allow the emergence of resistant disease, metastatic disease, and/or treat micrometastatic disease at an earlier stage. And really here, we're trying to prevent operating on patients with very biologically aggressive disease and try to prevent any futile attempts at resection. So in general, there are two main surgical approaches. The traditional open surgical approach which can be accomplished through a midline incision or subcostal incision, or now increasingly utilized as an MIS approach or a minimally invasive approach, either through the use of laparoscopy or robotic surgery. Now, this has many benefits over open approach, such as smaller incisions, which may lead to less pain and opioid use after surgery. And there are various studies which have shown that an MIS approach can lead to decreased length of hospital stay, and more importantly, decreased time to functional recovery. And so this is a meta-analysis here on the right-hand side of MIS versus open. And as you can see here, the length of hospital stay was shown to be improved or reduced using an MIS approach over an open approach in these randomized trials. Now, there are two main operations that we perform for pancreas cancer, depending on the location. And so for tumors in the head or potentially neck, we perform a Whipple operation or a pancreaticoduodenectomy. And for those in the body and tail, we perform a distal pancreatectomy. And just a very, very brief overview of the major steps of a Whipple operation. It's really divided in two parts. There's a resection stage and a reconstruction stage. In the resection stage, we try to optimize exposure. We perform a portal dissection. We isolate the neck of the pancreas and divide the neck of the pancreas to separate the head and uncinate from the body and the tail. And then we perform an uncinate dissection, which divides the pancreas off of the superior mesenteric artery, which is shown here in the bottom right. Now, the second portion of the operation is the reconstruction phase. And so once the specimen is out, there are 3 anastomoses that need to be performed. The first is the pancreatic jejunostomy or gastrostomy. The pancreas can be reanastomosed either to the jejunum or stomach. The hepaticojejunostomy, so reconnecting the bile duct to the intestine, and the gastrojejunostomy to reestablish enteral access. As I mentioned earlier, for patients with borderline and locally advanced disease, vascular resection may be required. And so this is a classification system for patients needing vascular resection during a Whipple operation. Type 1 involves resection of the side of the portal vein SMV and either a stapled or sutured closure that ensures that there's no significant flow limitation with the closure. Type 2 is if a significant portion of the vein needs to be resected, where primary repair would cause flow limitations. And so a patch is placed on it to restore the original caliber of the vein. Type 3 is complete resection of the SMV or portal vein with end-to-end anastomosis. And type 4 is similar, except when their end-to-end anastomosis is not possible, then some sort of conduit, whether biologic or artificial conduit, is used in order to reconstruct the SMV portal vein. And outcomes following venous vascular resection can be performed safely, and this has been proven in multiple studies, and can be performed with equivalent outcomes compared to patients undergoing Whipple operation without needing vascular resection, granted that it's done at a high-volume center by a high-volume surgeon. Distal pancreatectomy, just very briefly, involves isolation of the splenic artery and vein and division. The division of the pancreas either at the neck or proximal to the tumor, and then splenic mobilization and resection. And so the final specimen is seen in the top right and left. There is the cut end of the artery and vein there. The tumor is in the distal body/tail, and this whole specimen gets removed and resected. Now, postoperative complications are often due to the 3 anastomoses that I mentioned. And so on the left is really the crux of the operation, which is a postoperative pancreatic fistula. Now, the International Study Group on Pancreatic Surgery has developed standardized methods of reporting these different types of complications after surgery. And so for postoperative pancreatic fistula, the pancreatic jejunostomy or pancreatic gastrostomy leaks pancreatic fluid. And so if it's a leak that causes really no clinical deterioration or change in management, this is referred to as a biochemical leak. A grade B pancreatic fistula is persistent drainage over 3 weeks and or the need for some sort of intervention. And grade C pancreatic fistula requires things like a major intervention like reoperation or the incidence of organ failure and or even death. In the top right is the grading system for post-pancreatectomy hemorrhage. Similarly, it's graded A, B, and C. A has no clinical impact. B has mild to moderate clinical impact, and C is severe clinical impact and or life-threatening. And on the bottom there is the grading system for delayed gastric emptying. So a delay in the stomach to perform its normal function, which often requires things like an NG tube or for a patient to be NPO for a certain amount of time. And depending on the severity there is the grading system there, A, B, and C. Now, after surgery, there have been many studies looking at evidence-based methods to really recover patients faster. And so historically, this is kind of how we used to take care of patients. We often had them with prolonged fasting, had them NPO before surgery and several days after surgery, limited their mobility. Patients would receive routine bowel preparation, which often got them dehydrated, the routine use of drains and NG tubes after surgery, non-goal directed fluid management, and non-evidence-based pain management. And so these also contributed to an increased rate of complications after pancreatic surgery. And so more recently, in the past few decades, a multimodal approach referred to as enhanced recovery after surgery has been popularized. And this is a multimodal, multidisciplinary effort with evidence-based methods to care for patients after surgery, including pancreatic surgery. At its crux is active patient involvement, which includes patient education. And I think this is very important. It begins in the clinic with the proper teaching and expectation setting in clinic. Preoperative optimization, which we already went over. The use of minimally invasive surgery when possible and appropriate. Risk-based prophylaxis, and early enteral feeds after surgery. And again, I think one of the most important things is standardizing these methods, again, based on these evidence-based approaches. In 2021, we published our ERAS protocol after a Whipple operation, which followed the same tenets. And this is a brief presentation of the guidelines here. And what we found was similar to other investigators, that patients just did better after surgery when we implemented this ERAS protocol. So in brief, the length of stay was reduced, the oral morphine equivalent or the total opioid usage was significantly reduced after we instituted ERAS protocol, and more patients went home and had less complications and readmissions after ERAS was implemented. As I mentioned earlier, with vascular resections, those should be performed by a high-volume surgeon, but it is arguable that all pancreatic surgery should be performed by a high-volume surgeon at a high-volume hospital. Now, this volume outcomes relationship is not new. This was established in the 1970s and popularized in the early 2000s for a variety of high-risk complex surgical procedures. And the Leapfrog group has now established minimum volume standards for these different resections, including pancreas cancer resection, which defines a high-volume hospital as performing over 20 at your institution, or a surgeon performing over 10 per year. We looked at this in the Medicare cohort, and we assessed high-volume surgeons at high-volume hospitals and the interaction between the two, as opposed to low-volume surgeons and/or low-volume hospitals. And as you can see, patients undergoing pancreatectomy by a high-volume surgeon at a high-volume hospital had a 27% reduction in the incidence of postoperative complications, or a 27% risk reduction in the incidence of postoperative complications. Similarly, 90-day mortality was also reduced by 35%. And interestingly, this also translated to long-term outcomes. And so this is a hazard ratio of long-term outcomes among patients with pancreatic cancer. And those operated on by very high-volume surgeons at very high-volume hospitals had significantly reduced hazard ratios of death long-term compared to those at very low and low hospitals. Another method to assess outcomes after surgery is a metric called textbook oncologic outcomes, which is essentially just the ideal outcome for patients undergoing any type of cancer surgery. It's a one metric that's easy to interpret by stakeholders, particularly patients. And a textbook oncologic cancer outcome for patients undergoing pancreatectomy for pancreas cancer includes that an adequate number of lymph nodes were removed and examined. The patient received a microscopically negative resection margin. There was no length of stay outlier, no unplanned hospital readmission, and the patient received guideline concordant chemotherapy and/or radiation either before or after surgery. And so this would essentially be the ideal outcome for any patient undergoing surgery for pancreas cancer. We looked at it again among a cohort of Medicare patients, and we found that textbook outcomes were only achieved in about 1 of 4 patients among patients undergoing surgery for pancreatic cancer. And this was the lowest out of all the cancer types that we looked at, with colon being the highest at 65%. What was probably more important was that there was significant variation between hospitals. So the lowest achieving hospital was achieved a textbook oncologic outcome of only 3%, whereas the highest was 72%. And so this variation shows that there's much effort that needs to be done in order to create benchmarks for patients undergoing pancreatic surgery, and that it's done appropriately by the right surgeon and at the right hospital or institution. So in conclusion, pancreatic surgery is complex and requires multimodal and multidisciplinary comprehensive evaluation and treatment by high-volume surgeons. And it's strongly associated with long-term outcomes for pancreatic cancer. And so the more patients that we can safely get to surgery and through surgery, the better outcomes that we can achieve for patients with pancreatic cancer. Thank you again for your time, and please feel free to email or message me. Thank you again.